So, good morning, everybody who didn't run out of the room. Thank you very much for staying. This is going to be the patient perspective session. In terms of what we heard earlier, just as a couple of introductory remarks, what we heard earlier, a lot of it is, of course, future-directed that we are going to hear and think about in the next couple of days. So from the patient perspective session, we try to put together a session that actually shows best practice examples of what programs can do that are trying to access patient today and bring them together with modern science. And I'm really talking about European and international level best practice examples. The idea is, of course, that a patient is a citizen that has a disease today. And so many of the solutions that we're currently thinking about are related to the health sciences and solutions of future patients. But oftentimes, of course, the things that we are talking about will not help patients by the definition of having a disease today. And so I think what this session is going to focus on to try and show some of the examples of what you can do today and then transition that into systems that will work for us even better tomorrow. And so without much further ado, I would like to get into this session. The first presentation is going to be from the Dutch program on colon cancer. Manon Spander was so kind to come out here and explain it to us.
Thank you. I'm honored to be here in this very inspiring institute, and I really want to thank you for the invitation that I may speak to you today about the Dutch colorectal cancer screening program. And what I want to show you today is actually how the pilot studies and the data from the pilot studies helped us to set up a nationwide program and also the success of the program. But before I show you those data, first a little bit of background about colorectal cancer and why this cancer is so suitable for screening. First of all, the impact of the problem. So colorectal cancer is the second most common malignancy and the second leading cause of cancer-related mortality worldwide. And these are the data from Europe. And secondly, we know if we detect colorectal cancer at an early stage, so as you can see in this figure, if you detect it at stage 1 and 2, the survival of the patient will increase compared to colorectal cancer diagnosed at stage 4. These are the patients with metastasized disease. So by detecting the cancer at an early stage, by screening, the survival of the patient will increase, but also it will reduce the toxicity and invasiveness of the treatment because people with a stage 1 or 2 colorectal cancer do not need chemotherapy. There is another thing, the third thing why colorectal cancer is so suitable for screening is that in contrast to other cancers, colorectal cancer has a pre-malignant stage, the so-called polyp or adenoma. And by detecting the polyp and remove it by performing a polypectomy, you actually prevent colorectal cancer incidence. And this is not only the theory, this is already based by randomized controlled trials, performing a fecal test, the Motoric test, showing that by doing the fecal test, you have a reduction in colorectal cancer mortality of around 18%. And that was a proof of principle that early cancer detection can reduce mortality. And then there were the studies from the US, the national polyp studies, a study where they follow a patient with an adenoma after colonoscopy, showing that the incidence of colorectal cancer was reduced up to 90%. And later on, they also showed that people who had a colonoscopy with adenoma removed had a reduction in colorectal cancer mortality of 50% compared to the general population. So this was the proof of principle that adenoma removal prevents cancer and reduce mortality. And this helped them also to clarify the fact that you can see that there was a decrease in colorectal mortality in the US among men around the 90s. At first they could not clarify the reason, but when they look in those data, then they found that it was not only the fact that the treatment improved and that there were more risk factors identified, but it was mainly because of the contribution of screening, because most of the people underwent colonoscopies. So these are the current screening modalities we have today. So we have the non-invasive screening test, the fecal test, and we have the more invasive screening tests like CT colonography, a sigmoidoscopy where we examine the left colon, or the colonoscopy where we examine the whole colon. And for the fecal test, we have two types of tests. We have the FIT test, the immunochemical test, and the guaiac test. And the differences between those two tests is that the guaiac test detects the HIMSS group. So it means even if you eat red meat, for example, the test will also be positive because it also detects animal HIMSS. And in contrast to the FIT test, which detects the human globin of the hemoglobin. So it's a more specific test, and you can do it only once, in contrast to the guaiac FIT or the guaiac test, which you have to perform 3 times. What are the abilities of a screening test? So what does the screening test have for abilities to determine that it's a good test for screening? So first of all, the tests have to detect the colorectal cancer, and not only at stage 4, but especially at stage 1 or 2, and in all locations of the colon. Besides that, it also have to detect the adenoma, because when we detect the adenoma, then we can remove them and actually prevent colorectal cancers. And the third thing is the uptake. So people have to undergo, or have to willing to undergo the test, or redo the test. So what was the test that the Dutch population prefer, or better said, and this is what the Ministry of Health asked us, which test should I have to choose for our population, and giving us the highest yield of advanced adenoma and colorectal cancers? So this is this summarizes our data from the pilot studies we perform. And we performed the pilot studies in 10,000 average people in the Rotterdam area from 50 to 74 years of age. And we assessed all the different modalities. So the guaiac, the FIT, the sigmoidoscopy, the CT colonography, the colonoscopy, and 3 rounds of FIT. And we looked for participation rate. We look for positivity of a test, the true positivity of the test, and eventually the main aim, the true positive per 1,000 invited. And what I want to show you with this slide is, what happens? Is that it's not the accuracy of the test that determines the outcome of your program. For example, look for the colonoscopy. It has an accuracy of 100%, meaning if the colonoscopy finds cancer or finds a polyp, there is cancer and there is a polyp. However, if you look at the true positive per 1,000 invited, then you see that we found 19 per 1,000 invited. While we choose for a less accuracy test, like the FIT test, with a sensitivity of only 42%, we find more cancers, 21 per 1,000 invited. And when we perform the FIT test in 3 rounds, so inviting patients every 2 years, or screenings every 2 years with the FIT test, we actually find 43 positives per 1,000 invited. So it's not the accuracy of the test which accounts the success of your outcome, but it appeared to be the preference of the population. Because in the Dutch population, people were not very willing to undergo a colonoscopy for primary screening. Only 20% wanted to participate. While for FIT screening, 60% participate. So the preference of the population determines the outcome of the program, and not the accuracy of the test. And a second thing, what I think is important when you perform or want to set up a nationwide program, is the fact that small differences in participation rate. For example, the difference between colonoscopy and CT colonography is only 12%. But the 12% difference in uptake. For example, if you start a nationwide colorectal cancer screening program in Germany, and you have a difference in 12% uptake, it means in Germany, in the target population of 55 to 75 years of age, that you miss around 3 million people. This means in 30 times fully booked Olympia Stadium here in Berlin. So small differences in uptake will have huge impact on outcome. So if you look a little bit closer on the patients or the population preferences, because patients or population's preferences determines your outcome. What about giving screenings a choice? And let people decide by themselves if they want to go for colonoscopy or a FIT or CT colonoscopy. Would that help to increase participation? Well, actually, in this article, we summarize the literature, and there are 3 studies showing that there is no effect on participation if you give people a choice. So it will not increase your participation. And there's also 1 study from Italy showing an actually decrease in participation if you give people a choice. Besides choice, also information is important because, and this is more from an ethical part of view, if you want to participate people in a screening program, it is good that they can make a well-considered decision if they want to participate or not and be aware about the consequences. And if you not provide them with information, then people will look at the internet. And they will look at, for example, Google. And so did we. So we Googled colorectal cancer screening in Google, and we assessed the first 30 websites in English about colorectal cancer screening, and we assessed them for accuracy. So we looked at if all the information is complete on the website, how is the quality, how is the readability of the website, and this is our top 5 with the highest score of the English website on colorectal cancer with the most accurate and complete information. And now if we looked at the Google ranking and looking at our website, which we define as accurate and complete, then you can see 2 things. First, that the ranking of Google differs within the years. And the second thing is that only 2 of the websites that we found accurate is actually in the top 10 of Google. And knowing that people will only read the first page of Google's, accurate information will probably be missed by the population. So what about our national PACE program? Based on all these data, we set up the national program, and people from the age 55 to 75 years of age will receive this purple letter, and in this envelope there is the brochure with the information. It's translated in all languages, English, Arabic, Chinese, and it also contains the FIT test. And in case the test is positive, then the patient goes for colonoscopy, and if the test is negative, then 2 years later the patient will be re-invited for FIT screening. So this is schematically our infrastructure of the program. So in the middle you have our nationwide data system. It's called Screen IT, and we started it with colorectal cancer, but now we're also working for the breast and cervical cancer to be one screen or one IT infrastructure for all data of the cancer screening programs. And you can see here we start with the, let me see how this works here. We start with the town hall information to identify the patient who are 55 or 65 years of age, who are still alive and still living in the Netherlands. They get an invitation letter with the FIT test. They perform the FIT test at home. They send the test back to the labs, and the lab results come again into the Screen IT program. Then, in case the test is positive, the GPs get a letter that him or his patient has a positive test, and a few days later also the patients get a letter that he has a positive test. And not only they get a test result, but they also get immediately an appointment for an endoscopy center nearby within 2 weeks of time. Then at the endoscopy center also data from the intake will also enter in the nationwide data system. Data from the colonoscopy, from the pathology, all entered in the Screen IT. And we used all these data to monitoring, real-life monitoring, as evaluation to see the outcome of the program and for quality assurance. So we qualify or certify the endoscopists and the pathologists, and we use the data in the nation data warehouse system. So what about Europe? These here you can see the different colorectal cancer screening programs in Europe. In green, the countries with a population-based screening program as the Netherlands, where patients in the target population are systematically invited, while in orange, the countries with opportunistic type of screening, where people are more randomly invited for colorectal cancer screening. And the European Health Council have also defined some performance standards for colorectal cancer screening because of the problem in Europe. And they define the target population 50 to 74 years of age. And they want that the invitation is covered within the target population of 95% with a desirable level of at least 95%. And a participation rate in the target population of at least 45% and a desirable level of 65%. And this will be a challenge for the countries who have an opportunistic type of screening, in contrast to the more population-based screening programs. So what about our data? This is the schedule. We could not start the program and roll out it immediately because of a lack in colonoscopy capacity, and that's why we have rolled out the program within 5 years. So you can see from 2019, more than 2.2 million people will be invited for colorectal cancer screening. And in the first year, we started with 5 birth cohorts, 1938, 39, 1947, 49, and 1951. And this was the participation rate. So we knew from our pilot data that we had a participation rate of around 65%, just a little bit below the desirable level of the European Union. But when we started the program, we increased to a level of 70%. What about colorectal cancer incidence? So the colorectal cancer incidence was second in the Netherlands before we started the colorectal cancer screening program with around 13,000 people a year. And after the start of the program, it increases to 50,000. So now it's the #1 incidence of cancers in the Netherlands. And if we take a better look why it increases, then you can see that the birth cohorts that I just said that started the program, 1938, 39, 47, 49, and 51, the increase is seen in the birth cohorts that participated in the colorectal cancer screening program. And did we find the early cancers? And you can see it in this slide. The red and the yellow are the colorectal cancers found before the screening. So you can see that as most of the patients had stage 3 colorectal cancer, that is comparable with the symptomatic patients in 2015. So patients with symptoms, they are also commonly diagnosed at stage 2. And this in contrast to the screen-detected colorectal cancers, which you can see in gray, with an increase in the stage 1 versus the stage 4. So in conclusion, colorectal cancer screening programs will decrease the incidence and the mortality in time, but as I showed you in the beginning, you will have an increase of your incidence, fortunately at an early stage. There are well-developed CRC screening modalities or methods to screen, and I think by performing pilot studies, it helps to get insight in the prevalence of your population, and which helps to get the program successful. For example, as we did with the preference for the screening tool, because if we would start with colonoscopy, it would be not that successful, and also accurate information. And I think if you have those two aspects, that will help to increase participation, and still participation, I think, is the key to success if you talk about cancer screening programs. Thank you for your attention.
Questions? If I may start off with one. So you're basically talking about inviting a quarter of the entire Dutch population in this program? Is it a quarter or a fifth?
Yeah, a quarter.
A quarter.
But it's a target population, so it is not only the 55 to 75 years of age.
Yeah, but that age bracket forms a quarter of the entire population.
Yes, exactly.
Yes, and so you basically have 75% of those responding, meaning a fifth of the entire population is responding to this.
Yeah.
That's huge.
It's huge. Yeah. Yeah.
Amazing.
It is. Yeah, it's really amazing. And I think it helped by choosing the right test, because if we went for colonoscopy because that is the accurate test to perform, then we have only 20% of people who wanted to participate. So that helped.
And so that information of the testing in the patients is obviously almost digital. It's a yes or no. Is there any other digital information that you give to the physicians who treat the patients besides that? Is there, are you like storing clinical records or references to clinical records in the individual cases, or you're basically just scoring identity and yes and no for the re-invite?
Exactly.
Okay.
So all the clinical part is beyond it. So this is only the screening, so the healthy people, and if they want to participate or not, but you should also see a difference in participation. So people can, for example, say, I don't want to participate for the first round, but then after re-invitation, the next year they decided, I don't know why, just to participate. So it differs. Yeah, but you can see it's quite stable. It is around 70%. Yeah.
Okay.
Short question. I may have missed it, but how do you how do you market the test in the population? In other words, what do you find effective, most effective vehicle in getting a positive response? People taking up the test.
Yeah, we also did some studies about how we could have the highest yield of participation. And that's why we sent the fit test with the envelope to the patient so that the patient can do it at home. So in some other countries, people have to go to the GP. For example, in France, people go to the GP to get the test. And then you see that the participation drops. So this is helpful. And also the fact that the tests you can send by mail. So you don't have to deliver the test in any office or GP or hospital, is helping, we think, in participation.
Right. So what I was really trying to get at is one way is to make it convenient to perform the test. The other important thing with screening tests is that we found in our work is that how do you communicate the risk and what the benefits from the test might be in reducing risks in a population? That's a very challenging task. So how did you, in what terms did you present risks, colorectal cancer, and how the test can help to reduce the individual's risk?
I totally agree. I gave a short insight in the information, but that's the key, I think, for participation, but also for participants to make the well-considered decision of participation and what it implies if you do not participate. So in the beginning, with our pilot studies, we saw that people did not performing the test because they did not have any symptoms. So that was for us an important issue, that we have to be more specific in our information, that also in people, or especially in people without symptoms, performing the test, because also in asymptomatic patients, colorectal cancer can be present or the pre-malignant state. So these are informations we have gathered from our pilot studies, which are now included in the leaflet of the national program. But we're still working on it together with the patient organizations to get the leaflet much more clear, because we also had patients who underwent a colectomy and performed the fit test. So there's also patients who do not have to undergo the fit test, or people with Crohn or colitis who are actually performing the fit test. So the information to the patient has to be as accurate as possible. I think that's a key in these nationwide programs. Totally agree.
Okay. Any further questions? If that is not the case, thank you very much. I know that you're running, they're holding an airplane for you. You need to run.
I'm here.
Okay, thank you very much. Okay, so talking about the patient's perspective and talking about getting information to the patient, of course, calls for innovative ways of communicating with patients about their data and patients being able to hold data. So Sergej Binins is going to introduce us to a very innovative solution from Switzerland.
Thank you, Professor from Calais. I was very interested as a scientist in the previous presentation, and being a male in the club of the age 50 to 74, I was also, I felt concerned as a citizen, and I went through such a test, and luckily I wasn't one of the 21 concern from 1,000 invited. This magic number is true for 2 of the tests, so that way you don't know which test I chose. At MeData, we pursue a similar goal as was held in the keynote, and I would like to take one sentence of Paul Jones that told us that innovation can take up to 20 years to reach the clinic or clinical studies, if I got it right, and we try to shorten that by putting things upside down. We start with clinical studies and engage patient from day one in that. How do we do that? I will show you in the next minutes. This is the plan. I will briefly talk about data aggregation, but that has already been handled, so I go quickly to that, and then illustrate it with one use case. Then I will explain you the governance and the platform of MeData and why it achieved its goals, and share with you a few lessons learned. Well, data aggregation, if we take the metaphor of the Google Maps of health, well, Google aggregates on the geography different information like roads, shopping, elevation, boundaries, and we want to do something similar around the patient. We show genomic information. We also heard how difficult it is to link that to clinical data, to outcome data, lifestyle, nutrition. Well, the way to do it is, as we heard, to engage the citizen and the patient. Well, we also target thousands of patients, starting with smaller cohort, and we also target to do it internationally. Well, this is the summary of the MeData approach. We allow citizens to open their health digital account to integrate different data sources, and it is their account. They decide with a dynamic consent to which study they'd like to participate. Each owner owns the key that allows the decryption of its health data. The goal is new treatment. The project has been studied in Switzerland through a partnership with ETH Zurich and the University of Applied Science in Bern, and we started the first clinical study with university hospital in the neighborhood, and now we are doing some international partnership that I will come back to. Well, let's start an illustration with the use case. One of the first challenge we heard about by talking with a researcher in neurosciences is the case of the multiple sclerosis disease. Each patient has a different disease. The evolution is very slow, very difficult to identify what are the factors, and to evaluate the positive impact of a new treatment is a very difficult task. The differences might be very tiny, and clinical studies often fail to identify slight positive impact on the outcome. So the goal was to allow to have thinner outcome measures. Today, patients have to go twice a year to the university hospital. It's very costly for the clinician. It's also very costly for the patient. If they are suffering from the disease, then it's difficult to travel. And if they are in a healthy phase, they want to do something else than clinical tests. So we try to move from paper tests to allow them to do measure of their motoric capabilities and cognitive capabilities through the use of mobile applications. We developed new tools, and we calibrated those tools through a citizen science project involving healthy citizens. The final goal, ultimately, will be, after having deployed those new outcome measure tools, to evaluate the new treatments. Well, here are an example of those tests from that use case. The first one is association of symbols and numbers. By the second one, participants are shown a path on a labyrinth. They have to remember it, and after a few seconds to reproduce it twice correctly in a row. Quite a challenge. I was part of the citizen science part to work on base data to do it. We also developed tools to measure the motoric capabilities of the hand and on the forearm. In the first example, they have to move 3 blue dots to the gray ones on a tablet or to follow different lines. These are just examples that I wanted to show you. It's also complemented with the questionnaires. Well, I don't have much time now, but these are the different use cases that we are deploying, so it's not specific to multiple sclerosis. We also support clinical research for patient outcome after bariatric surgery for people that have undergone stomach bypass. They document on the mobile application their weight, the number of steps they do daily, and I'm telling you, those are not the quantified self young sport people, and they agree to do that. They document also their well-being, how they feel. They can do that on a scale and also on text. One surprise for us was to see that they document in the Swiss dialect and not in High German, so it's really their diary, they are driving the study. You see other examples and patient-reported outcome, the physical activity, the mood, the pain, the quality of the sleep is something which is relevant in oncology, in psychiatry, and in neurology. Well, how do we do that? Well, we bring together, was also underlined in the keynote, the different stakeholders, patient, researchers, and clinician. We do that through an IT platform, which is on the cloud, and that platforms communicate with the different stakeholders, mainly the patient, with mobile application. We found out that most effective and much a closer interaction with a general portal. We developed within a few weeks a mobile application per clinical research, per use case, per pathology. As I mentioned, the acceptance is very high, and people get different direct feedback about curves, about the evolution of their symptoms, and then can decide what parameters they want to share for studies. Well, it's not only about technology. MeData Corp, as previously mentioned in the keynote, is also an independent structure, not in the form of a for-profit company. It's a not-for-profit cooperative. We believe that as for blood donation, the collection of data has to be not-for-profit, but research and the involvement of the industry can be for-profit in outside of the data management space. So the MeData Cooperative has managed through its General Assembly edict governance rules in the form of Act of Association, and it has also its own ethic committee, not to replace the ethic approval of the clinical studies, but to give approval of the general condition, the small letters that people click by using an app. We want to make it readable, understandable by the patient, and also to look over the different partnership that we're engaging with. This trust-promoting framework is built, as I mentioned, on a cooperative model. It's one member, one vote. So it's citizen-driven initiatives. I also mentioned the not-for-profit aspect. The source is a customized open source model. Any regional organization that agree to the ethical and governance principles can reuse the platform. The data is secure through encryption, have undergone several security audits. and the whole solution can be deployed regionally, and I will come to that in just a moment. I'd like to share a few lessons. We learned quite a lot over the time, but I will address those 3 types of lessons learned. Well, what is the benefit to engage patient from the start is by doing such, we plan on dynamic consent and 1 consent per study. So not the general consent, because we aggregate so much data that it gives a lot of information on the patient. And by engaging them from the start, we still have a very high participation rate. By engaging the patient and giving them access to their personal health record and to the data collection information, they are ready to document how they live, how they feel, because the healthcare system is just not only about diagnostic and effect of medication, it's how people evaluate their health. And having the patient controlling their data, we plan collection of geolocalization, nutrition profile, and so far we have a high acceptance rate. And through that information we can collect environmental data. Our next project is to collect symptoms of allergy, link that to meteorological data like pollen during the season. The second type of lessons we've learned is the motivation of the patient. The main one is to be part of a study. That way they also commit to engage over the time, and they also see a direct benefit because they are suffering of a disease and they want to support any kind of new treatment because they are waiting for it. Of course, the trust it's not only the IT platform, it's the combination of face-to-face relationship with the clinician or researcher. But once we can build on that trust, then we can interact electronically in a very efficient way. And now what we are working on, because we still face that after a few months, the interaction through mobile application, there is a dropout rate that anybody in this business experiment. And we are working on closer feedback, building a community around the projects so that we keep the participation rate high over the time. And the third lessons we learned is that the principle of engaging people basing on explicit consent is something which relies not on the economic and financing system of the healthcare system, but on data protection law. They are complicated, but they are similar in all countries, also similar between Europe and Switzerland. And if you address and get the consent of the patient, then you can deploy the technology I shows independently on the local organization of the healthcare system. And we are experimenting that with a partner that you see on that list. And with that, I will conclude, and I'm ready to answer your question. Thank you.
Thank you. Questions? I might start with one. So this did not require any changes to laws or any regulations in Switzerland?
Not at all. Well, there are two laws. One about research on humans, so you have to go through ethical approval. And the other one is the data protection law, which in Switzerland requires the informed, explicit consent. And through the interaction of the patient and the clinician or the researcher, we ask for that consent, and in a highly rate we get acceptance.
And the data that goes into that system is the entire record of the patient, also imaging studies and things like that, or a filtration of that, or where are you with that?
We are working on that use case per use case. The first project, it's patient-reported outcome, what they enter through the mobile application. We're now aggregating data from different sensors, and now we're working on integrating clinical data.
Okay, and last question from my part, who pays?
It's financed through the clinical research, so the mobile application are very light to build. We built on international standard like FHIR, Fast Healthcare Interoperability Resources, and we have a framework that allows us to do that very efficiently. And the backend has been developed through research grants.